Hello, everybody, and welcome to today's meeting. Welcome, Professor Marco. It's nice to
Welcome.
see you again.
Me too.
Yeah, so today we have the fifth and last webinar in our series of digitalized solution in placing implants with Professor Marco Tallarico. It's my pleasure. It's our pleasure to have you all here again tonight on Zoom. And as you know, Professor Marco will present the second lecture of finalization stage of the complete arch cases with considering the aesthetics. So please let me introduce again our guest. You already know, but I will introduce again Professor Marco. He is president of OIC Europe. He is DTS, Master of Science in Oral Surgery, Director and Research Project Manager of Austin OIC Italy, and certified in implant-based therapy, European Association of Osseointegration in 2013, assistant professor at the Department of Medicine, Surgery, and Pharmacy in the University of Sassari in Italy. He is expert in digital solutions and more than 120 publications in peer-reviewed journals and private practice limited to dental implants and prosthodontics in Rome, Italy. So before we start, please make your phone and the video off. And if you have any question, please write it down in the chat section. And after the webinar, we will have a short survey. So please fill it. It will help us to understand your demands. And it's our honor to have Professor Marco today with us. So
it's my honor. I will share my screen.
Okay.
Okay. Can you see my presentation? I think so.
Yes.
Okay, I will go. First of all, thanks to welcome me in all of this webinar. I know I brought you 5 times. This is the last. No, I'm joking. I'm really sorry because in this webinar we touched a lot of topics and maybe without the possibility to go deeper. However, as Steven said, I became director of the scientific community OIC Europe, but my idea, my plan is to have only one scientific community. So I'm really sure that we will have more and more option to go deeper in the dental field, in the digital technologies, in everything, starting from the meeting in Dubai. But before also, we will have a new meeting, new webinar with Professor David Chong that I really suggest to follow. So starting my lecture, this is the second part of the last section. We started with pre-visualization, digital technology to plan implant solution and aesthetic solutions. Then we see guided surgery, execution, and immediate loading, implant placement. In the last webinar, we focus on digital solution with OSEM for partial cases. And today, I want to focus on complete arch restoration finalization. I have a not very, very short, but I will go a bit fast in this introduction just to show it, to explain why you should use some abutments, convertible abutments, multi-unit abutments, why we should use from a biological and mechanical point of view. First of all, how do we make the selection of the abutment materials? You know, I love guided surgery, so we can plan in advance the use of convertible abutment, multi-unit abutment before the surgery start, because we need to understand the implant position and what kind of abutment, what size of the abutment we need. So the answer is we have to plan the final prosthesis, including the abutments that we want to use before surgery at the time of the planning. Look at this case. I already spoke about scan, plan, done, and make. This is a complete arch restoration. scan the prosthesis of the patient, reference point, in this case, gutta percha point, our planning, 3 implants on the right, 3 implants on the left, and here we can plan the implants, but not only the implants. Here we can see the prosthesis walks up, that is the white outline. We can measure the distance from the soft tissues. Soft tissues are outlined by the internal portion of the prosthesis. We can plan in advance if we need bone reduction or the use of bone profiler to prepare the bone for the setting of the prosthetic component. And in this case, we can plan the height, the angulation, diameter of the abutments. In this case, we plan 6 multi-unit abutments. I will show in a few minutes the reason. After that, the impression, you can see here the multi-unit abutment, 2 millimeters high in the back, 3 millimeters high in the anterior and in the middle portion, all straight because we plan, as you can see, 3 parallel implants in each side. I will explain with some completed cases the procedure. This is an FP3. FP means fixed prosthesis 3. 3 means that the final restoration is composed by white teeth and pink gingiva. But in this case, we have removable overdenture. I will talk with other cases about removable overdenture because I love this kind of prosthesis, because it's a fixed bar, as you can see on your left, is a metallic contour part, as you can see in the middle, and then we have the white teeth. So the difference between a Toronto bridge are some attachment that you can see on the left that are very important function. First of all, to make the system more elastic, because implants are rigid, zirconia rigid, metal are quite rigid, and we need some shock absorber materials. So Toronto bridge can have some complications, such as mechanical complication, but also biological complication. Using this kind of prosthesis, we can reduce, of course, mechanical complication, but also biological, because the patient can remove and easy clean. Here, the CAD/CAM project. On the left, the bar. On the right, healing cap on the multi-unit abutment before the titanium bar is screwed. And here, the composite material. This is a novel PMMA that is bonded on the resin materials in the removable overdenture. As you can see, removable overdenture can support the tissues because we have the flange both in the buccal and the lateral part of the patient mouth, but we have the possibility to remove and the patient can clean perfectly the implant, reducing a lot the risk of biological complication. The attachment that you can see on the top of the titanium bar also allow for more resilience of the system, shock absorber. So also the prosthetic complications are completely reduced and easier to fix. And this is the radiograph at the follow-up and the patient. So the aesthetic is good, but we have not so much expensive prosthesis, but with a very low risk of biological and mechanical complication. So a step back on the abutment, we have a lot of criteria that we can take into consideration before choosing the abutment. Implant abutment interface, restorative platform, profile of the healing abutment or interim abutments, angulation of the implants, interocclusal spaces, and also deeping of the implants. So regarding the first step, I want to introduce some research. This research allows to understand how are important the implant abutment interface. And I publish a lot on this topic because I think is very, very important. For example, this is a systematic review on survival and success rates of different shoulder design. And we found that if we done a very good prosthesis, bone level implants and tissue level implants presents the same amount of bone resorption. Tissue level implants, often have the SS implants that are very nice, are used, I use a lot in the posterior mandible or maxilla in case of thin biotype, in case of periodontally compromised patients, in case of diabetic patient, in general, smoking, in general, in some patients that are compromised or thin biotype, where the cleaning of the emergence profile is to be is a priority instead of aesthetic, so posterior region. Even if I place the implants correctly with a bone and with a good prosthesis, bone level implants could have we can expect the same remodeling of the bone. However, mostly in thin biotype, I should place my implant deeper in order to anticipate the bone remodeling. So tissue level implants, particularly in thin biotype, could be very important, but mostly in partial cases. In completely dentous arch, bone level are the favorite implant type. We have difference about our connection, you know, and today we spoke only about two pieces implants, but we know that in two pieces implants, even if we have a good connection and even if we have a good prosthesis, we have a micro gaps. Micro gaps is inevitable. These micro gaps can be a gateway for the bacteria, but also for micro movements, leakage and infiltration. And in this systematic review, I concluded that all the implant abutment connections are contaminated. So the question is to maintain the contamination at the level that are quite tolerated by the organism. And with the internal connection, conical connection, we can reduce micro movements and we can reduce the micro leakage. And this is the review that concluded with significant results in order to presence of bacteria, particularly in compromised patients. So what about the connection? Internal connection is fantastic from a surgical point of view because allow flexibility of our implants. We can place the implant deeper because internal connection seal very well. Before I spoke about micro movements and micro leakage. It's not possible to place external hexagon implants or flat-to-flat connection very deep because the micro movements create a lot of bone loss. So you can imagine implant deeper, soft tissues, deepening of the implants, bone resorption. We have a long probe that is not possible to clean by the patients. So external hexagon implant must to be at the bone level. Internal connection implant must to be placed deeper. And today, doctor loves internal connection for aesthetic reasons. We place the implant deeper. For also anatomical reasons. If we have some resorption of the crest that is quite thin, a way to avoid a big bone reconstruction is to place the implant deeper. However, we can with internal connection. But on the other hand, internal connection is dramatic from a prosthetical point of view. So just in case single implants, no problem. Parallel implants in a short span is no problem. But in case of longer partial or full arch is very, 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 very complicated to close the prosthesis at the implant level. And we need to convert. External connection, on the other hand, is not good for the aesthetics, emergence profile, etc., but is fantastic from a prosthetic point of view because allow the compensation of this parallelism of the implants. Look at the in the middle flat-to-flat connection. We have a lot of opening. So these create micro movements, micro leakage, pumping effect, bacterial in the connection that go inside and go outside, and this create inflammation. Inflammation create bone resorption. So we need a stable connection, as you can see on your right. So what are the technical and biological concerns? I spoke before. In this case, we have a gap between implants and prosthesis because the dental technician use a castable abutment that create a not good fit. So in that gap, even if it's a microscope, it's a good big gap. Bacteria can go inside, but also you can see the rugosity that is very high. So this is very dramatic to collect bacteria and to collect and to determine inflammation and bone resorption. And in a series of papers with a colleague of mine, we stated that perimplantitis could be also determined by prosthetic triggers. So we know today that perimplantitis could be a multifactorial origin. Also, prosthesis, microgap, overloading, cement can contribute to developing an infection of the implants. And this has the results of also systematic review about one abutment one time, definitive abutment placed at the time of the surgery and never removed, significantly better bone response and soft tissue response. Less marginal bone loss of quite 0.3 millimeter, less buccal resorption of quite 0.2 millimeters. But also a friend of mine, Pablo Galindo Moreno, published several manuscripts about the profile of the abutment that must be narrow, concave profile or flat profile and higher. So in order to have an abutment, stable abutment, no compression, and go out, go in height in order to go far, to move far from the bone. With this kind of design, you can see on the picture, all of these factors that I spoke before allow to reduce the marginal bone loss. So just to summarize, completely dentulous patient with implants is quite impossible to place all the implant parallels. Internal connection are good, flexible from a surgical point of view for the aesthetics, but not for the correction of the disparallelism. And all the micro movements, even if reduced, are at the bone level or deeper. So we need to convert with some abutments, multi-unit abutment, convertible abutment, in order to seal immediately the connection, one abutment one time, to move the inflammation at the tissue level and not at the bone level, because we know that at the tissue level are more tolerate instead of bone level. Internal connection is very tight respect of external connection. And platform switching that is inside the implants. All of these factors, including narrow and longer implants, allow to maintain the marginal bone loss around our implants to a zero value. But it's most important that we plan in advance. I already spoke about implants, angulation, and interocclusal space that we can plan at the moment of implant placement. And it's very important also because according to the space that we have, we can plan the dipping of the implants. And I will stress you in all of my presentation that is very important also because the occlusal space is very, very important to allow the minimal and the correct, the right thickness of our materials, restorative materials, in order to reduce complication. In this slide, you can see that we have the possibility to screw retain, cement retain, or standard abutment, customized abutment. We already spoke about this concept in my previous webinar. In Fula, I love screw retainer restoration. I use in all single, partial, and multiple restoration. But in the complete large restoration, with also some literature that clearly stated that screw retainer restoration is better. Also because the main benefit of the screw retainer restoration is the retractabilities. That is very, very, very important. So what kind of abutment we have? From Austin, we have multi-unit abutment, straight and tilted, but we also have convertible abutment. Convertible abutment are in the middle, are narrow and shortened respect the multi-unit abutment. Multi-unit abutment have conical shape, so usually I use a lot of multi-unit abutment, but in some case, convertible abutment could be very nice. In my opinion, convertible abutment could be better in case of partial restoration. If you have tilted implants, I showed in my last webinar, I think, however, I will show in the meeting in Dubai, anterior cases, GBR with not parallel implants that I resolve with convertible abutment, but multi-unit abutment are my favorite in full arch restoration. Maybe the best could be to combine multi-unit abutment in the posterior, and if you need convertible abutment in the anterior, because are narrow profile and sometimes could be important. For example, also in case of thin biotype, in order to avoid compression. And then tilted abutment that we need when we have tilted implants to correct the angulation. For example, in case of Olom 4 or in case of pterygoid implants, zygomatic implants, and we need to correct. This is a case with cemented restoration. I showed partially in my previous webinar. I go fast because in this case, 6 single abutments pre-planned before the surgery. I already told to you in my previous webinar. But in this case, I don't need convertible abutment because I put the abutment and then cemented on the top. One abutment one time could be very important to reduce inflammation due to unscrewing of the link abutment, transfer abutment, try-in, etc. So if we place the implant at the time of the surgery, never remove, could be better. This is a zirconia framework. Today I use zirconia monolithic, but in the past I published this manuscript, I think around 2015 with a 5-year follow-up. So these pictures are about 2010, 13 years ago. The first zirconia, you can see also is very, very white. And at that time, we used single lithium disilicate crown on the top. Honestly, it was fantastic because from a mechanical point of view, the old zirconia was very, very, very strong, but from an aesthetic point of view, not good, but cementing on the top, lithium disilicate was very nice. However, the price was very, very higher. Today, we can have a good aesthetic results with zirconia monolithic. That is most favorable for the patient from an economical point of view. And this is single crown on the mandible. And this is zirconia framework, lithium disilicate cemented on zirconia abutment, customized abutment. Honestly, I have not a lot of cases with cemented restoration. However, cemented restoration is quite easy because it's very similar to the conventional prosthesis on natural teeth. I want to move in my webinar with screw retainer restoration, where we need to use this abutment that I showed you before. Why we should use this abutment? Because, as I told you before, ostium have an internal connection of 11 degrees. And there is a geometrical rules. We can perform flat to flat bridge on tilted implants up to 22 degrees. However, at 22 degrees is the maximum, but it's a flat to flat connection. We lose the benefit of the one abutment one time. But even this, in case of complete arch restoration, so very often we have more than 22 degrees. For example, anterior to posterior, left to right implants. So in order to seal the connection with the internal connection benefit, in order to allow more compensation, more degree compensation, we can convert. With convertible abutment, we can set passively the restoration up to 40 degrees, more or less. In case of multi-unit abutment, if all the multi-unit abutment are straight, we can reach also 45 or 46. But in case of straight, tilted multi-unit abutment, we can also go around 104 degrees. The maximum is 90, otherwise the implants are opposite. It's not possible, but we can convert, for example, 40, 45 degree implants in case of all-on-4 anterior implants, and we can convert up to 90 degree with a convertible abutment about 40 degree. That is that is enough. And these are some benefits comparing with the convertible abutment and the multi-unit abutment. So depth of the implants, I already spoke about the depth of the implants, but the main concept is the biological width. Biological width is a very, very important concept. You know, all of us know that we have a junctional epithelium, we have a connective tissues that allow for the biological width, that is a system to protect the bone. Up to the junctional epithelium, we have the sulcum epithelium, that is the variable part of the system that protects the implant or the tooth. So it's most important that all of our components protect and doesn't create any problem to the junctional epithelium and the connective tissue. But also, it's most important also the passivity of the prosthesis, as I told you before. After this, I'm so sorry, fast introduction, because it's very, very important topic, I want to show you some cases. During these cases, I want to speak about materials, number of implants, position, and occlusions. Maybe if you can see this webinar later with a little bit more time, if you want some of this manuscript, I will share with you. But just in brief, all of us know that we have a lot of problem with the complete large restoration, also in the partial. Fracture, wear, technical complication, particularly in this paper, focused on the resin-based materials. After a lot of years of experience in my practice, resin-based restoration, Toronto Bridge, have to be considered temporary restoration. Could be 1, 2, 5 years, but are not stable enough in the medium and long term. Some example, metal resin composite, metal ceramic, ceramic to ceramic. And I will show you some example, particularly the last example is my gold standard today. Also in this consensus conference from the Italian Scientific Society, we gave some guidelines, ceramic, titanium in the base connector, and we know, all of us know that we need to use metal to metal in the connection, and then we can bond zirconia on the top. Zirconia is good materials, and we can use also as a monolithic, and like this example, in order to reduce the chipping of the ceramic materials. Regarding the number of implants for atrophic patients, the gold standard, in my opinion, is 6 to 8, and also to reduce the failure, because when we have 4 implants, we have in the long term more marginal bone remodeling, but the failure is slower because the implants are in anterior. Implant in the posterior area can fail a little bit easier, but if we have bone, I suggest 6 implants, sometimes also 8, because with 8 implants, we can split the complete large restoration in 3 single bridges. In case of bruxism, in case of long span arch, maybe 8 implants is better. Zirconia, as I told you before, is a good materials, like a framework, but today also as monolithic. This is FP1, fixed prosthesis 1, that means only white with normal tooth 8. FP3 with the pink and white, but we also have FP2 that is maybe the poor prosthesis from an aesthetic point of view, that is long teeth but not pink. In the past, a lot of patients wants FP2 because they maybe pink seems to be removable denture, but today all the patients accept FP3 in case of atrophy of the bone. And I will show some example of this kind of prosthesis. Like this, I will show this case in my last case of today. What about the occlusion? Just some feedback, because this is a very long topic. Just a couple of examples. Full arch restoration, patient that came with a temporary restoration. We need to improve vertical dimension. I improve vertical dimension when the mandible is go forward, and with the centric relaxation, I bring the mandible in the correct position. So I can improve of 2-3 millimeters without changing the length of the muscle. So I am quite sure that we will have not complication in the time. But most important is to test the new vertical dimension with the temporaries for at least 2-4 months, depending of the case. In this case, zirconia, in the posterior monolithic, in the anterior ceramic fused to the zirconia. In case of complete arch restoration, fixed, I use anterior guidance, canine and incisor guidance, but with a small group function. As you can see in this case, in the blue, the centric contact on the functional cusp, but in the red, you can see the left and right guidance, not only in the canine, but also in the first premolar, a small group function. In the anterior, all the incisor are a little bit the canine, so a small group function. In case of single, just functional contact. This is some tips in order to check the contact point. And another case. This case, I want to show you the occlusion in case of removable denture that is completely different. This patient plans for implants to support a removable overdenture. However, removable denture in this case was very dramatic, so I delivered immediate loading, 8 teeth without cantilever, just for the period of osseointegration. Immediate loading usually must be not functional, but in case of complete arch restoration, I give group function lateral and in protosive. Copy of the planning and all of the cases that I showed you before, you will see copy of the temporary, copy of the planning. This is the key of the success in case of completely arch restoration. This is overdenture. You can see the flange, the framework, as I showed you before, the bar in the patient mount, but we can deliver a prosthesis with that can support the tissues. The patient can eat very well. Aesthetics is the same, FP3, but the resilience of the system is higher, and the risk of biological and technical complications are very reduced. So, as I told you before, group function in case of the temporary, but in case of the definitive restoration, overdenture supported and retained by the bar, I use the same occlusion that I showed you before, a small group function. But in this case, the patient has in the upper jaw a completely removable denture. So I use a balanced bilateral occlusion. Like in the blue, only lingual contact. Then when the patient move, it's very important that we have contact on the left and on the right simultaneously, otherwise the prosthesis can move. Balanced bilateral occlusion is the classical occlusions in case of removable denture. What about digital? Just some tips. Sometimes when you take an impression, you see this message overlapping. What is the overlapping? Look at the right. This is a big image. Overlapping means that anterior, maxillary, and mandible teeth are overlapped. But what is it? What is the overlapping? Overlapping, yes, of course, could be that the occlusion is not taken good, but in case we are sure the occlusion is good, overlapping is because when the patient close in ECP position, intercuspal position, that is the maximal incuspidation, the natural teeth have a periodontum, so the teeth intrude a little bit. When we close the occlusion, this intrusion means that is the amount of the overlapping. This is very important because according to the amount of the overlapping, we can see also some colors in the map, and we can determine what kind of contact we want. The same with the bite papers. If the patient close, now I use a progressive papers that allow me to have a different amount of color, very similar to the color map. What is important? It is important, for example, in case of implants, that the implants are a little bit under occlusion because when the patient bite, grind, the periodontal ligament allow the tooth to intrude a little bit and the implant contact. If the implant contact at the same moment of the natural tooth, the patient cannot use the shock absorber after of the periodontum. So using a progressive paper of 100 microns, we can set the occlusion so that is very, very light contact, but is more colored on the natural teeth, so that when the patient grind, the periodontum intrude, but the natural teeth no, the implants no, and when the implants touch, we have an equilibrium. How many microns? The periodontal ligament allow compression from 0 to 100 microns. So it's important with a digital solution to calculate the overlapping. Without digital solution, with the papers, we should have, with a progressive paper is very nice because we have a light blue and a more strong, more heavy blue in case of natural teeth, light in case of the implants, because means that teeth can intrude and implants not. So the concept is to leave the implant in small under occlusion in case of slight contact, and the same contact in when the patient have a heavy bite. So it's not easy concept, but I hope to give to you a little bit tips to think in this way. Very fast, because I have maybe 5 or 6 cases, but just to show you some tips. This case is a full arch in the lower mandible. Patient needs some extraction because there are some infection. Analog, I will move with my cases from analog to digital. As you can see, articulator, lower and upper jaw. I need to extract virtually these teeth because I started with an analog approach, I digitalized, and now I'm in a digital workflow. It's a mixed workflow. In the past, I use a lot the mixed workflow. In the blue, the actual teeth. In the yellow, the walks up. I need to follow the walks up for my planning and see the difference. The natural teeth that must be extracted are buccally oriented because the mandible goes forward, no posterior stabilization. This is my planning, 6 implants according to the yellow workshop. Immediate loading, as I showed you in my last webinar. So I can go fast because I already showed that with the guided surgery, we can plan in advance prototype model, reinforcement, temporary restoration, all guided with metallic sleeves, the surgery index, and we fix the pin, extraction, and guide, preparing for the implants. This is the old kit, so I can skip. Implant placement, 6 parallel implants. Remove the guide and place the multi-unit abutment, and immediate loading in about 30 minutes. 4 months later, impression, we can put the temporary restoration in a model. We have took an impression, gypsum impression. I will show in 5 minutes, 10 minutes, how we can do in the digital. But look at this example, using the temporary restoration in a cross-mounting technique. In this case, some stamp with a silicone, according to the plan. What are doing? We create the stamp of the temporary restoration. We set the temporary restoration in the articulator so that the dental lab have the final implant position with the volume of the temporary restoration. When the dental lab digitalized the volume of the digital of the temporary restoration, he moved in a dental CAD software, and it's very easy to design a titanium framework to allow composite teeth. So the key of the success is the planning. The planning allow immediate loading. Immediate loading is the plan functionalized. After that, we scan the temporary restoration. In the temporary restoration, we import the final implant position, and it's very easy to finalize the work. In this case, FP3, normal teeth, pink aesthetics on 6 implants. Not needed for all-on-4. We have bone for 6 implants. It's very easy to management. I want to show you this case because I received this patient for this problem. The patient told to me, oh, this is a definitive restoration, but she also have a temporary restoration. Both are poor, dramatic. The first is broken. The second doesn't allow this one for hygiene maintenance. 6 implants with a bar, with a very big abutment, thin biotype, implants buccally positioned, and she spent a lot of money. So what I can do? Implant retention, of course, minimal invasive, low cost for the patients. Implant retention has some limits, risk of peri-implantitis, of technical problems. Implant removal, new prosthetically driven implants with all the risk and cost. Implant removal limits are, for example, the risk of complication and higher cost. So I decided to maintain, but to put some narrow convertible abutments. Narrow convertible abutments. 5 years ago, I tried to take an impression digitally, but I failed because the range of this parallelism go from 65 to 86. So finally, gypsum impression and put the model. However, as I showed in my last webinaries, I started again with first impression, second impression, vertical dimension of occlusion, phonetics, aesthetics, central action is very, very important in order to reduce the risk of failure. Most of the failure are for poor diagnosis and poor treatment plan. So finally, this is the workshop, the correct workshop. So now in in normal situation, I use the walks-up to plan my implants. But in this case, we already have the implants. So I push every time. Occlusion, function, aesthetics, position of the teeth, we need to plan in advance, not after. In this case, it was very complicated. However, we digitalized the conventional impression. As I showed you before, the disparallelism was very high. But what allowed the digital? The digital allowed to plan the prosthesis and to test several types of prosthesis. In this case, my first choice was overdenture, because if you remember, the limits were mechanical complication, biological complication. And as I told you before, overdenture allowed to reduce the mechanical and biological risks. However, overdenture required a lot of space, so was not possible because not the sufficient amount of thickness. I also tried 2 or 3 separate bars, the same, no space. One piece removable, the same, no space to guarantee the medium-term success. Look here, very 1.7 millimeter, not enough, not enough. So finally, the only possibility was Toronto bridge, but with a lingualized titanium bar. And also we took the option to exclude a couple of implants because completely out of the prosthetic project. And with the angle driver, we also have the chance to move the holes for screw and screw the prosthesis in the pink area of the prosthesis in order to improve the aesthetics. This is the bar. Look at the implant. The bar is completely lingualized. Titanium bar, composite teeth and resin. As you can see here, no screw, just some attachment, the same attachment like the removable prosthesis, just to be clear. And here, closed with pink materials. Con pink composite, we closed. And we have some follow-ups. No periimplantitis, no problems in the follow-up. The patient is very happy, and at the moment, no more complication. So moving to some digital, some inside the digital, this is a case that I performed and published in 2018, 5 years ago. My first completely digital workflow in fully edentulous patients. 2017, sorry. I started in 17, maybe finished in 18. So the patient, as you can see, need a prosthetic flange because without the prosthesis, have not support for the lip and for the cheek. The patient already has a completely removable denture. This one also very good. I already introduced, if you remember, the protocols for guided surgery, dual scan, marker 3D, or anatomy. In this case, we use a dual scan, DICOM plus STL. Van Steenberg published in 2005, DICOM plus DICOM, and I published in 2017, DICOM plus STL, using composite materials as a reference point, as you can see here. The first scan, DICOM, the second scan, STL, impression, and superimposition. Then to develop the digital model from the internal portion of the prosthesis. So we have the anatomy, the works-up, and the DICOM file, the 3 data that we need. This is my planning. In this case, 4 parallel implants. I didn't tilt the implants because with an overdenture bar is not needed. I didn't place a 6 implant because I plan removable overdenture. This picture showed 7.2 millimeter of prosthetic flange. So If we move to a fixed prosthesis, we have, look at my mouse, or we need to remove all the flange. The prosthetic profile started from here, but we have not support for the lip. If we want the support from the lip, we need to reduce the bone, move the implant, short implant, and starting the platform from here so that the emergence profile can support the soft tissue. So always FP3, but fixed, we need to reduce the bone. Classical protocol all on 4 that I showed in my last webinar. I suggest to read this paper from Marianne Avrampou, very interesting. So the surgery, I go fast because I showed the execution in my last webinar. I just want to start from here, multi-unit abutment, impression, but we cannot believe, we cannot trust in this impression. We know it's not still predictable in all the cases. So I published this prosthetic template. What does it mean? It's a copy of the prosthesis that I used to place the implant with 4 holes in the implant position so that I can take an impression with some reference point. And this is the step that I used for 5 years. Now I move to one step more. I will show you in final cases. But why? Because in the full arch, the impression is not predictable because between the scan body, the scanner is not so much accurate. But if we put some reference point, the scanner is more accurate. It's very similar to a partial edentulous patients. Look here, implant position and teeth. And we use the first impression to copy the situation of the soft tissues. And why is important? Because using the teeth as a reference point, I can also match the final implant position in the plan. And then it's very easy to finish the prosthesis because look at this picture. Transparency, we have the volume of the teeth to be rehabilitated. Here we have the final implant position that are accurate because taken with the prosthetic template. Final implant position, volume of the prosthesis is very easy. We don't need a new Facebook centric action to test the aesthetics, to test the phonetics, because the key of the success is to copy the plan or the temporary, that is the plan functionalized. Prototype models, overdenture, titanium bar and counterpart. Just to check the occlusion, or we can move directly to the try-in of the aesthetics. Individual mandibular movements. 5 years ago, we finalized in analog way with composite teeth and acrylic resin. But look at the flange, very high, to support the lip and the cheek. This is an FP3 removable, so the patient can remove and clean the titanium bar, maintaining the level of the implants at the day of the surgery. Look here, at the day of the surgery. And the smile in the aesthetic is very good. Very fast, this case, the old prosthesis, even if it's not beautiful, is like a Cinderella, become a princess, because implants, not placed by me, but I scan the prosthesis. Because I transform, I print from the prosthesis a customized impression tray that I named prosthetic template. So take the impression with the reference of the teeth of the prosthetic template. This is the impression. Look here. This is 5-6 years ago. Today is more accurate. However, the original prosthesis, Cinderella, you remember? Impression impression of the soft tissues, impression of the splinted impression of the implant position, matching, and once again, transparency, the volume of the teeth to be rehabilitated with the implant position. I'm sorry for the implant position. I didn't place the implant, just remake the prosthesis. This is some test, but this is a zirconia framework with lithium disilicate crown. I told you before that in the past, I delivered some of these prostheses. Today, I would finalize with the monolithic zirconia. Very, very easy, without take care of the aesthetics, antagonists, phonetics, function, because I use a functionalized prosthesis with the current vertical dimension and bite occlusion, if I don't need to change, of course. And this is a follow-up. So I showed this case last time. I want to show us the case is finished. I promised. These are the patient at the beginning, diagnostic prosthesis, new removable denture. You remember the healing, all on 4 in the upper, lower over denture, implants, I showed it in the last webinar, and finally, temporary restoration, all on 4 in the upper maxilla. The protocol is quite similar to the protocol that I showed you before. Impression of the soft tissue, and from the temporary, I took impression of the soft tissue on your left, impression of the temporary on your right. So I can match together this impression, and I can create easily in software, this case is excellent. I can create whenever I want. But look here, superimposition of the temporary. As I told you before, we can use the temporary or the plan. I prefer the temporary because the plan allows me to place the implants. Then I can modify the immediate loading that derived from the plan. Immediate loading derived from the plan and functionalized is my reference point because it's the best. Planning, functionalized is the final prosthesis that I want. So the key of the success is to have a very functionalized and aesthetic temporary restoration. We can easily have a good temporary restoration if we plan in advance. So finally, the final prosthesis is a better copy of the plan. Implant position, and this is the mesh of the temporary restoration. This is the alignment of the scan abutment to define the implant position. Very easy in the CAD software. So what are the steps? To have the final implant position and to have the volume of the functionalized temporary restoration. So with this first impression, because what is the problem? Dental technician cannot believe in this impression. Not yet. Is accurate in 75, 70, 80% of the cases. In 20, 30% of the cases is not still accurate. So this impression, digital incomplete large, is used to create the prosthetic template. Before I showed the opened prosthetic template to fix the scan abutment. Now we move in a little bit different situation, the similar prosthetic template that we use also to test aesthetics if you want to change something. It's a copy of the temporary, maybe make it better. But it's not with a big hole in the implant position, with a small hole. So we can fix some temporary cylinder and we can put on the back the scan analog or reverse scan. A lot of company, and I asked to host them to develop the scan analog or reverse scan. because we can easily fix on the temporary. So what is this impression? It's simple splinted impression. The same that we can take with the gypsum, but it's a splinted on a template, prosthetic template, that is a copy of the temporary. Or we can also, if the temporary restoration is completely passive, the fit is good, we can also put the scan analog or reverse scan directly on the temporary restoration. I prefer the prosthetic template because I can rebase, so I have the position of the soft tissues. But companies are also moving to have a reverse scan and internal impression and to superimpose these two impressions. So we have the impression of the soft tissues and we can have the position of the implants from the temporary. Even if seems to be complicated, believe in me, is easier than seems. But I want to focus once again in one important concept. Planning. Planning allows the correct three-dimensional implant position. That is the key of the success. Planning guided surgery allows to easier immediate loading. In complete arch restoration, after implant placement and immediate loading, and today with the digital technologies, we can make these steps easier and faster. We did 90% of the job. After integration, we have several protocols and we are looking for the best. Reverse scan body are probably the best to finalize the very easy in a 3 steps, the final prosthesis. So I have about 3-4 minutes just to show the finalization of the case and the last solution that is a difference. But here you can see that we can plan the titanium bar, the position of the teeth very easily, and we have a lot of space. If you remember the case that I showed you before, where we don't have space because we didn't plan at the beginning. In this case, planning at the beginning, we have a lot of solution. This is a test of the impression just for research reasons. This step will be avoided in the future. Look at the case, very good tissues, titanium bar. Very beautiful sound. And final.
No, sorry, doctor. Can you please open your mic? Okay.
Okay.
Thank you.
Yes, maybe just you lost once again the importance of the planning as a copy, as a starting point for the final restoration. So this is my last cases. I just in 2-3 minutes, I want to show you what is my gold standard today. This is a very passionate patient for my clinic. I follow her since 2010 or before. This is the situation when she came in my clinic. I started to place 2 implants in the left maxilla, then other implants in 2017 in the upper, then some implants in the lower, another implants in the lower. Finally, this is the upper cemented restoration, very similar silicone material, because it's always important to have a prosthetically driven implants. Cemented on the zirconia, as I showed you before in 2017, but in the lower, as you can see here, a zirconia, monolithic zirconia cemented on a titanium bar. Because I told you before that I use a lot of zirconia. I also told from the guidelines of Italian Scientific Society, OIC Italy, that the connection between the implants and the prosthesis must be in metal. So what is the problem? Zirconia is a very good material from a functional and aesthetic point of view, but have a very big limits, two in particular. The first is that a lot of opaque, is most opaque. However, the new zirconia are multi-layered. From an aesthetic point of view, are very nice. The problem remains with the fragility, tenacity of the zirconia. In case of small restoration, the zirconia is very good, but in case of large spam, the problem is that zirconia can create some internal problem and become more and more fragile. So to work with the zirconia without problem, we need to follow the protocol, starting from the milling, from the sterilization, from the lab. For example, it's very important to have a long time for cooling. It's very, very important. But if the zirconia is just painted, the temperature for painting is just low. So, and then very, very long time for cooling. However, we should need a very precise impression in order to avoid any kind of tolerance. So, very often this is not enough, and we need some different solution to compensate the zirconia, and the solution is the cement. We can have cemented retainer restoration, as I showed you before, lies in the upper, cemented retainer restoration, but the retractability is not good. Okay, I have a question. I wonder how we can manufacture the bar around the multi-unit abutment. You can manufacture the bar around the multi-unit abutment in two ways. If you want to use original component, there are the I don't know the name, are like the coping, metal coping for multi-unit abutment, and you can cement metal to metal. However, multi-unit abutment from Ostem are compatible with the most important brand in the world. So you can ask to the milling center to give to you a bar directly on the multi-unit abutment. I completely agree in the original components. And of course, I am of this principle. However, if you use multi-unit abutment, you are sealing the connection. So it's very important that implant abutment connection is secured with the original abutment, original screw, because tolerance, microleakage, infiltration are very dangerous. So if you use original multi-unit abutment, you can ask to the milling center to mill the titanium bar directly to the multi-unit abutment. It's very easy because it's an external connection. It's just conical. It's very easy. And you can use original screw. With my milling center, I produce the bar. Maybe I have some picture. I don't know if I have a picture on the back. Directly on the directly on the multi-unit abutment. I have not the imaging here, with original screw. In this case, are directly on the implant platform. With the multi-unit abutment is better, but you can ask to the milling center. Some milling center can do it, some not. In this case, are directly on the implant platform, but is better on the multi-unit abutment because it's easier and safer to connect the connection with the multi-unit abutment, and then you can design the bar directly on the multi-unit abutment using the original screw. I think all the milling center can do it. However, with this bar, you can, this is a prototype, then you can cement the zirconia, you have some tolerance, but at the end, the results is an hybrid prosthesis. is screw retained, but screw retained outside the patient mount. So you can have a retractability, but between the titanium bar and the zirconia, with the cement, you can compensate any micro grep you have. And depending of the situation, you can also produce 2 or 3 smaller zirconia bridge and cement separately, because it's most important that the zirconia framework is not so long, otherwise the management is not easy. Due to my presentation is finished, this is the final restoration. I just want Stevens try to share a CAD design. Just 1 second, just to show, because I received one question. I try to find it. I need to share again my screen. Desktop 1. Okay. Okay, you can see my screen?
Yes.
Steve? Okay. Oh, very nice sound of kids. I love. So this is a CAD design of the bar. I want to show you just for the question. For example, I just removed some object. Okay, is this? Okay, this is the titanium bar, and the milling center can mill the titanium bar directly to the multi-unit abutment. And you can ask for the original screw, because the connection with the implant is deeper, because you put the multi-unit abutment, so you can secure the implants. I didn't find the other model. But otherwise, the other option is to use the link for the titanium abutment, original screw, and then to cement metal to metal. But honestly, I think that if the milling center can produce the bar directly to the multi-unit abutment with the original screw, is better. Okay, Steven, I finish. I maybe 1 hour, a little bit more, but I hope, even if I put a lot of cases, I hope I did some tips, some feedbacks about the importance of the planning, the implant position, guided surgery allowed a lot, importance of the immediate loading, and how it's possible and quite easier to finalize the full arch restoration if we have a very good and functionalized temporary restoration. I showed analog, digital, mixing, novel technique, etc. But the key of the success remained the planning. So I want to thank everyone, you for the invited me for all of these webinars. From my point of view, we set this webinar just to start. As a president of a scientific community of OIC Europe, you know, Stephen, for me, it's not Europe, it's only one community. So I'm really sure there will be a lot of other occasions. I also want to ask to the doctor that attend this meeting or the other meetings to leave some feedbacks how was the meeting, how was the limits of the meeting, what they will be in the future from the scientific community, because it's very important that for me and for the company, these webinars are the option to share the knowledge, and to share the knowledge, I think, is a very, very precious and important. So I really want your feedbacks in order to continue to improve this sharing of knowledge between us, starting from the next webinar and Dubai.
Yeah, sure. We have made a survey after this meeting. I ask everyone to give his feedback, so it will help us so far to know your demand.
But not the good I don't want the good feedbacks. I want the very easy that
Okay,
are more important for me.
everyone be frank and just
No. It's most important for me what is possible to improve.
Sure. Okay, thank you, Professor, very much for the presentation and for all the webinars. It was all very informative and like a high level of digitalized solutions. And it is stored on our YouTube channel. Anyone can come anytime and revise it. I personally revise it from time to time, so I think it's very useful.
Me too. Sometimes I revise my lecture.
Yeah.
And I give my students.
Yeah, sure. It will be helpful. We can share it to other people for general knowledge.
Sharing knowledge is something amazing.
Yeah. Okay, so for now we finished our webinar series. Hopefully we will have another series again with Professor Marco. But for now we will have next month we will have another webinar. I will share my screen. So, okay.
Good speaker and friend of mine, but very nice speaker.
Yes, he's Professor David Chan. He's from USA. So he will be speaking about the soft tissue management around the implants. So to ensure the maximum function and aesthetics for the long-term functionality. So we are expecting for you to come and attend this webinar. It will be Friday, 15th of December of the next month. And then we have our big event, which will be in February. The Professor Marco will be there, sure. And it will be in the 5th February in Atlantis Hotel in Dubai, here in Dubai, in 5th February 2024. So we are expecting you to come because we will have a great speakers and very prestigious event. So let's meet our speakers. So first one, of course, is Professor Marco Tallarico, as you know.
They already know me.
So yeah, so he will be, of course.
Sorry, Stephen, it's completely different. This webinar more oriented to teaching and to give some tips. In February, I will show some new cases focusing on aesthetics in compromised patient. And I'm preparing new cases.
Okay, that will be very great. We are expecting to see you face to face in this kind of event. So that will be so much better than. Okay, and our next speaker will be Professor David Chan, which we will invite him the next week in the online webinar. He is from New York University, and also he will be speaking about the journey between the analog and the digital solutions. So it will be very, very important lectures for anyone who want to start digital dentistry, digital implantology. So it will be very useful for him. And we have our great doctor from South Korea, Dr. Yongjin Kim. So we also are expecting a very great lecture about the digitalized solution as well. And our last combo, two speakers, they will be having lecture together at the same time. They are from Egypt, Dr. Ahmed and Dr. Muhammad, Dr. Ahmed Ashraf, Dr. Muhammad Al-Ashri. They are from Egypt, from Alexandria University. So we will find the cooperation between the periodontology and the prosthodontics. So this is a cooperation between them. So we are expecting you, save the date, it's February 5, 2024.
And Stephen, we also plan, I have very high expectation on the final roundtable to discuss all together the lecture,
Yes.
but particularly the transition and the role from the analog to digital technologies, because we said to improve from transition digital in several cases and finishing complete large, but I have a very high expectation also from the round table that is always very important for the attendance and for the speakers too.
It can be the most important part because we will receive people's questions.
Take at home a lot of informations, a lot of good information. And it's open, it's interactive roundtable.
Sure, we are expecting this very much. Okay. So so far we finished our webinar series. So thank you, Professor Marco, for your great efforts and for your great lectures.
Thank you to all the audience.
You're welcome. And yeah, thank you to the audience and everyone who participated and joined us. It was our honor to host every one of you. And I will just leave you with a video about the Dubai meeting, just a teaser video. Okay, so have a good day. Thank you.